Welcome back to another episode of Single Payer Radio. Single Payer Radio is a project of Kentuckians for Single Payer Healthcare. We're an affiliate of the Kentucky chapter of Physicians for a National Health Program, and we're proud to be a community partner with Forward Radio WFMP 106.5. And just to let our listeners know, we'll probably be renewing our community partnership here in the next week or two. We're recording today's show Wednesday, March the 10th, 2021. And today, sometime, the stimulus bill goes back to the U.S. House of Representatives. And it's got some good things. $8 billion to federal, local health agencies for vaccinations, including targeting underserved communities. $7 billion to community health centers. $26 billion to Native communities. And then for states that have not expanded Medicaid under the Affordable Care Act, this bill will pay those states more as incentives to expand. And the bill will also double state block grants up to $1 billion for mental health services. I want to remind folks that the pledge drive here at Forward Radio is coming up. That will be March 27th through April the 9th. We'll have special gifts for donors. Check it out. Go to forwardradio.org. 4 years ago, we flipped the switch to go on the air. So please support the shows here on Forward Radio, both locally produced and national. Go to forwardradio.org. And because you'll never know who you might hear on Forward Radio, this past Sunday, I tuned in to Ralph Nader's show, and lo and behold, Ralph is interviewing our own Kay Tillow about the scam involving Medicare Advantage, or as they like to call it, Medicare Disadvantage. Way to go, Kay. And then also, just let me plug a new show entering our lineup here at Forward Radio. It's called Community Control. I listened to the episode about police and the Klan last night. Very interesting, crucial reporting. Great job, Vincent and Michael. Look forward to more. Another reason to support the unique programming here on Forward Radio. And the views and opinions here on Forward Radio are those of the speakers and not the station. Okay, let's get to our doctors. Dr. Michael Flynn, Dr. Eugene Shively. Morning, guys.
Good morning.
Good morning.
Good to be here. Let me begin with the usual disclaimer as well that any views expressed by me today represent my own personal views and do not represent the views of the Department of Surgery or the University of Louisville.
This is Dr. Shavli. My views are that of my own and do not represent Taylor Regional Hospital nor the University of Louisville Department of Surgery or the University of Louisville. Mark, I'd like to ask a question about that new bill. Do you remember how much was going to rural health care?
I did not see that when I just did a brief glance at the summary.
Okay.
All right, so topic today is part two of our, we did a program about 2 weeks ago on the administrative costs of healthcare in this country, and I think I'd kind of describe it as the administrative overload of healthcare in this country. So, and we'll get into it a little bit in a little bit about these administrators. Who are they? How many they are? What do they do? What do they get paid? And what impact does this have on healthcare? But before we do that, what I'd like to do is to set a few fundamentals on the table. We did this last time in a bit more detail. I was hoping that we might do this kind of briefly this morning, and then get into the details. So let me begin with a couple of fundamentals, and then ask Gene to do the same discussion about the finances of healthcare and where the money goes and how much of it is used for healthcare and how much of it isn't. So fundamental number one, in this country, healthcare is considered a commodity, a product like a grocery or the gas you put in your tank to run your car. The other 35 first world countries consider healthcare an essential public service and a government responsibility. Now, they've figured out a number of ways to provide health care for all of their citizens, whereas in this country, we have somewhere in the neighborhood of 90 million people who are either uninsured or underinsured and vulnerable to medical bankruptcy. Medical bankruptcy is the number one cause of bankruptcy in this country. We have somewhere between 200 to 800,000 filings for medical bankruptcy every year. And I wrote a paper about this for Louisville Medicine a year or so ago, and in doing the research, I really couldn't find very much about medical bankruptcy in other countries. I finally found one article that indicated that there was one, I'm going to repeat this, one medical bankruptcy in the country of France, 70 million people, in 2017. We had Ted Young on here in one of our shows last year discussing the differences between the Canadian and the American systems, and Ted basically indicated it just wasn't an issue up there. Now, these other countries have all figured out ways to provide health care to all of their citizens. The National Health Service in the United Kingdom has been around since the 1940s, and they run everything. They do the hospitals, the physician services, the pharmacy, and it's all managed by, it's funded by general taxation. Up in Canada, they have a single payer system that covers the cost of the hospital and physician services. Doesn't cover the pharmacy, doesn't cover dental, and the money is provided by the federal government, and the states or the provinces run the systems. And there's a whole bunch of other different ways that Israel and Australia and New Zealand, other countries, Scandinavian countries, run their healthcare systems. In both Canada and in the United Kingdom, private health insurance is available if you want it. So in this country, we really don't have a healthcare system. We have I've heard it described as a patchwork or a crazy quilt of an assortment of different entities that have different functions within healthcare. They're not integrated. They don't work together. They're just all part of our healthcare situation. We have Medicare, a government-funded health insurance for citizens over 65 and some groups with special disabilities. And we have Medicaid, which is a government-funded health insurance for people with financial difficulties. And this is a partnership or a collaboration between the state and the federal government. And unfortunately, because of that, this is different things in different places. A previous governor in Kentucky expanded Medicare, so in Kentucky, Medicare coverage is pretty good.
You mean Medicaid?
I'm sorry, you're right, Gene, thank you. Medicaid in Tennessee and Texas, Medicaid coverage isn't very good, and so it's different things in different places. We have a number of nonprofit healthcare systems, the VA system, which is not a perfect system, but it seems to work well for the veterans that are eligible for it. They run hospitals, have a pharmacy, they have outpatient clinics. The three branches of the military, Army, Navy, and Marine Corps all have their own healthcare systems run by the Department of Defense, and these are both nonprofit systems. And then lastly, we have over 1,000 for-profit health insurance companies, many with 10, 15, or 20 plans that have created this insanely complex system of establishing what's covered for your health care. So having gone through that, Gene, maybe I could ask you to discuss some of the financial issues that you've done such a good job of researching. I know we talked about this the last time we did this. This is kind of part two. But I just thought it would be helpful to kind of go through the fundamentals before we got into the specifics.
Well, we're the most expensive healthcare system in the world. We spend approximately twice as much money on healthcare as any other first world country, and yet our results are not that good. Depending on how you determine what good results are, most people calculate us as being in the middle. We spend approximately $3.6 trillion on health care. Approximately 1.2 of that money, it doesn't go to health care. It goes to things like for-profits, equity companies, owning nursing homes and hospitals, and essentially our healthcare system has evolved from the early 60s through the present time from a profession to an industry. It's taken a long time, but now it's picking up speed. And Biden is proposing a system where we'll have a private option to compete against private insurance. We'll have to wait and see how that works. But we're wasting.
Saying a public option?
Yes, a public option. The interesting thing is that as that evolves, the for-profit insurance companies are advancing their profits. For example, the Advantage plans have, since 2017, have increased 41%. The Medicaid managed plans that are hired by states have increased 53%. And so the private health insurance companies are increasing their profits. For example, an Advantage plan costs about 18% to administrate, while Medicare alone costs less than 2%. The reason that states are hiring for-profit companies to manage Medicaid is because it's convenient. You can just give a company some money and they can take all the headaches away. But the data shows that if they keep it within the government system, that it's much cheaper to run.
Well, all these administrators that we'll be talking about, I mean, what they do is they're figuring out ways that the money in the system isn't used to pay for health care.
That's correct.
Medicare has got a 2% administrative cost. The country of Taiwan has a universal health care system, and less than 2% of the resources or the money in Taiwanese health care is spent on administrative costs, and over 98% is spent on health care. So what we're going to talk about today is who are these people? Why are they there? What do they do? But basically, as Gene has shown, a third of the revenue in healthcare in this country is not spent on healthcare. So let me. I have three information sources here. The New York Times business section on the 9th of June 2019, the Bureau of Labor Statistics, and the Harvard Business Review. And they all basically show the same things. Numbers may be a little bit different, but they're in the same range. From the mid 1970s to the mid to late 2010s, the number of healthcare administrators, managers, bean counters, whatever you want to call them, increased an astonishing over 3,000%. Over 3,000%. So there are 10 of them for every practicing physician, every physician. So healthcare has gradually changed from taking care of patients to doing paperwork and computer work for billing. Now, I was in the Navy for 20 years. I was 2 years on active duty, and I spent 18 years in the reserves and worked in naval medical facilities in this country and overseas. And the Navy's got flagship hospitals in Bethesda, Maryland, and Norfolk, Virginia, in San Diego, Naples, Italy. As a physician in the Navy, you are a medical corps officer. If you are a health administrator in the Navy, you are a member of the Medical Service Corps. So whereas in civilian health care in this country, there are 10 administrators to every physician, in the military system, and I'm pretty sure it's the same in the Army and the Air Force, there are more medical corps officers than there are medical service corps officers.
Well, another interesting thing that's going on, which I think is fascinating. Many of you may remember that 2.5 years ago that Amazon, J.P. Morgan, and Berkshire Hathaway came together, and they were going to form a health insurance company to try to reduce the tremendous cost of health care. And, that's a lot. Those companies are three of the largest in the country, and they've got a lot of power. And they hired actually a surgeon. He's from Boston, works at the Bingham, and he's done a lot of writing as an expert in healthcare. His name is Dr. Atul Gawande. He is an actual surgeon and knows a lot about healthcare. Well, just a few weeks ago, the company, after 2.5 years, is disbanding. And one of the reasons is that they couldn't control things. You would think that those companies, with the amount of money they have, could control things, but it's really not in the hands of the companies. It's in the hands of the insurance companies, in the for-profits, and if you can't control the profit, then you can't control healthcare. He made some really interesting comments that I read this week. One was, he said that we cannot control healthcare without the government intervention. I thought that was very interesting. It's saying that the government has to get involved, and hopefully we're going to see that happen. It's not that we're going to have a socialized system. We may preserve a system with private insurance where people can make a choice, but the government's going to have to make some regulations. For example, for-profit insurance company could involved in the companies like utilities that are controlled with heavy regulations. Be like a utility company. The other interesting thing he talked about was a lack of continuity of care and investment into a patient's medical adventures, and stating that should be someone who is a primary care physician who knows the patient and who follows them for a long period of time. We used to have that, but now we've lost most of that. We have patients going to hospitals, their primary care physician is not involved, and then they see multiple physicians they don't know, and there's no emotional, there's no personal care. And this also dramatically increases the cost of medicine, which we have, it's totally out of control in my opinion.
Gene, every other first world country has recognized the necessity of doing this. Israel has a universal health care system. It took Japan 10 years to transition from a system like ours that was run by insurance companies to a universal health care system that is similar to some other ones but different. They're funded a little bit by the central government, a little bit by the local governments, a little bit by employers, a little bit by employees. I mean, all these different countries have figured out different ways how to do these things. Saudi Arabia, not exactly an example of raging socialism or human rights, has figured out that provides good health care for all of their citizens. They don't have 90 million people who are uninsured or underinsured or vulnerable to medical bankruptcy like we do. So, I mean, I think this is the clear way to the future. Now, the problem in this country, at least in the short run, is that the political will is going to be, I think, lacking as long as we are as closely and intensely divided as we are. I mean, the CARES plan that was just passed, or I guess is going to be passed today, is based on one vote. I mean, there's 50 in the Senate and 50 Democrats and 50 Republicans, and there were no Republicans supporting this. So it's going to be a while. I mean, I would hope that that some public option gets established, and I would also hope that people will recognize the importance of having a system that is not driven by profit, by simply driven by the need to give people health care coverage. And if they can get that going, I think that would be, at least in my opinion, that would be the first step toward getting to a point where we would hope to have something, some kind of single-payer system in this country like they do in all the other first-world countries.
Well, you can have a single-payer system that works, and it can still be a semi-capitalistic system like in Germany and Switzerland, where the government tightly regulates the system so you can't take advantage of it, but the patient or the person who's buying the insurance can decide what they want, but everyone has to be covered and everyone is taken care of, but you can still have free choice. There are a lot of people who are so concerned about socialism. Well, it depends on how you define socialism, but the German system, in my opinion, is not really socialism. And of course, most of the countries in Europe And most of the countries, the first world countries that Mike's talking about, are capitalist countries. They've just figured out a way where we can come together with government supervision to provide health care at a reasonable cost and for everyone.
Yes, and that
Gene, I was just going to say that the system that Kentuckians for Single Payer Healthcare advocates for is a publicly financed but privately delivered healthcare system.
Right.
And when you talk about government intervention, I think we talked about this earlier this winter when there was that story on 60 Minutes about Sutter Healthcare Systems up in Northern California, where they were just gobbling up hospitals and other practices, that those hospital monopolies that dominate a market, they raised their cost where prices were 70% higher in Northern California than they were in Southern California.
Yeah,
That's totally crazy.
I think we may see more of that because of the endemic.
Oh, yeah.
And there are a lot of hospitals who are not doing well, particularly rural hospitals. If you have a large company comes in and buys those hospitals, then they usually take the profits out of the small hospitals, and they usually diminish what those hospitals are doing. I think that's a very serious problem, and I think we're going to see more and more of that. But if we have strict government regulations, then we can stop that. I mean, it's just like we talked about capitalism. Capitalism is a great system, but Wall Street has to be regulated. The market, when the market fell in 1929, the main reason it fell because there was nobody controlling it. It got totally out of control, and it was being run by big for-profit banks in New York. So if the government had to step in and control things, you couldn't buy, $1 million worth of stock on 10% margin. That's what was going on.
this deregulation has been going on since Reagan stood up and said the government is the problem, not the solution, which is just, this is an ideological belief. Quick comment before we get back to that. Every one of those other first world countries, Gina, I would absolutely agree with you. Scandinavian countries that have very strong social programs, they have market economies. Australia, New Zealand, Canada, South Korea, Japan, on and on. Italy, they all have market economies. These are not communist countries. These are not. Sweden is a socialist country, but most of the other countries are not. And most of the healthcare systems are situations where the government provides the funds, the health coverage, and that the system of health care is not run by the government. That's true in, I think, Taiwan. I'm not sure about Japan, and it's true in the United Kingdom. But Australia, New Zealand, Canada, Norway, all those other countries, they have this two-part process, and in most of those places, private insurance is available if you want it. Now, the next comment is we were just talking about. There's this magical place that exists. It's called the competitive marketplace, the competitive healthcare marketplace. And this is a magical place. No, there is, where everything gets taken care of by the marketplace, and the marketplace will correct all these things, and everything is going to be wonderful at the end of the day. Well, everything is wonderful at the end of the day for the corporations and Wall Street and places like that. Now, the best example of how this magical marketplace works is if you have anybody paid any attention to what was going on in Texas, the energy, yeah, no, really,
I know.
it was insane. These people down there have these beliefs, don't tread on me, don't regulate me, and so there's no control over anything, and this totally deregulated environment just collapsed.
Right.
And I agree with you. It absolutely, there needs to be some sensible regulatory process that controls our economy as well as healthcare, and it's going to take a while.
Well, we need to also realize, I'm not proposing this, but I want you to understand that the British healthcare system is a socialized system, but the Brits are very happy with it. They just had a celebration last year, and they're extremely happy. And you need to remember how they got where they are. They voted that in. As a matter of fact, Winston Churchill got defeated over that one issue right at the ending of World War II because he was opposed to socialized medicine. The Brits wanted it, and so they voted him out. I think he got reelected again, and they're very proud of their system, and they're very happy with it. I'm not saying we should have a system like that, but I think we can have a system that provides care for everyone at a reasonable price, and it just has to be regulated. Just the data I just quoted you, where a third of the money we spend doesn't really go to health care. And so we can eliminate that and save a lot of money. For example, advertising. There's no other country in the world that advertises hospitals, drugs. New Zealand, for some reason, allows them to advertise drugs. We are responsible for half of the entire drug bill of the entire world. Why should we be paying for that much money for drugs where no one else is? I mean, we're charitable, but there's got to be a limit to that. We can eliminate the administrative costs. Just the administrative cost of medicine alone represents about 34% of the excess costs in our healthcare system. Why should nursing homes be run by equity companies? I mean, I think we're all interested in making money, but I think there's a difference between making money selling cars and groceries as compared to taking care of sick folks. I really think that making money on sick folks, other than salaries, which are reasonable, is immoral. Now, speaking of money, let me give you some prices on how much some the CEOs of these big healthcare companies.
All right, Gene, you tell me yours, and I'm going to show you mine.
This is
a G-rated program.
This is the S&P 500 companies and the healthcare companies, and CEO of CVS makes $36.5 million. That's about 390 times more than the people who work for CVS. And the poor guy at the bottom of the list is the CEO of Cigna. He makes $19.3 million, and that represents excess pay of $6.5 million, and his ratio to the average worker at that company is 360. So those poor guys, I don't know what they do to make that much money. They must be extremely smart and manipulative. I can't imagine anyone deserves to make that much money as a CEO.
Well, let's get into the specifics of this with the for-profit health insurance companies. But let me. I've got some numbers here as well. These are This is CEO compensation from 2019. This is United Health Services, a fellow named Alan Miller, getting $23 million. Columbia HCA, a fellow named Milton Johnson, another $20 million. Cigna, David Sindaris, $18 million. I mean, this stuff goes on and on and on. But I've got the absolute king of CEO compensation for from for-profit insurance companies. And this is going back a little bit. I wrote a paper for the Louisville Medicine about 20 years ago. There's a guy named William McGuire who was the CEO of United Health, and in 2003 he made $94 million and change in 1 year.
Now, McGuire was a doctor, wasn't he?
He was a pulmonologist, yeah.
You got to do a lot of spirometry to see a lot of patients.
Well, it sounds like capitalism works, but it doesn't work for the small guy, the little guy.
Exactly. That was my whole point about this magical place, the medical marketplace, where magically all these guys, the fat cats at the top are doing fine, and the crabs are scrambling around down in the bottom of the barrel looking for the scraps. But when this guy retired, he had billions of dollars. And after the crash of 2028 and the Sarbanes-Oxley Act, they clawed back a bunch of resources from him, but he still had hundreds of millions of dollars. It's absolutely insane. All right, I'm going to ask a rhetorical question. Okay, what is the purpose, the goal, or the mission of these investor-owned for-profit health insurance companies?
To make money.
Exactly. It's to make and keep as much money as possible.
But it should be to take care of patients.
I know, but taking health care is the vehicle that allows them to do this. It is not their goal. Their goal is profit, and they make no secret about it. The actual cost of paying for health care is called a medical. Think about this: medical loss ratio. That's the cost of paying for health care.
It's interesting that last year, 2020, that the insurance companies were bringing in more money. Their medical loss ratio, I guess you say, it's increased, and so they're not supposed to make more than 20%. So now they have this big problem. Are they going to give it back? What are they going to do with it? Some companies are now providing more services, transportation, free meals at home, dental care, ophthalmology care, et cetera, try to get away from paying the money back. If you remember, Blue Cross Blue Shield became a for-profit insurance company in the 90s. And before that, they were a non-for-profit. If they made an excess amount of money, they would often refund money to the people that they were insuring. They would decrease their premiums. And this is the way it should be. But now, no, they see how much money they make. And the other interesting thing is that the more charges they have, the more money they make. Because if 20% of $2 billion, they make more money than 20% of $1 billion. And so it goes on and on and on. There's a motivation actually to increase the cost.
So let's just talk about this process. So you pay a premium to a for-profit health insurance company. Where does the money go? Well, as you alluded to earlier, Gene, it goes to administrative costs. And there's no question that there are legitimate administrative costs. Medicare has a 2%. Taiwan has less than 2%. Advertising, huge waste of money. You know, I was watching the news last night before I went to bed, and I went from Fox News to CNN to MSNBC, and I would change the channels because of the advertisements, and most of the advertisements were about drugs. And
Right.
some of these drugs I wouldn't know what they were all about. I have to go look them up. I mean, it was just this endless barrage of information about something that might, a monoclonal antibody that'll maybe extend your life, and go talk to your doctor about it, and something for arthritis, something else to get psoriasis off your skin. It was on and on and on. So that's advertising.
Well, some of these drugs are good, but no one else in the world advertises it. It's the decision is made between the doctor and the patient. And some of these drugs are miracle drugs, like the drugs for Crohn's disease and ulcerative colitis, and some of the new cancer drugs. And at home, we've got several patients who had lung cancer, and now they don't have any evidence of metastatic disease. It's phenomenal. But there's absolutely no reason that you should advertise for this.
Yes, absolutely. I mean, and I agree. You know, the targeted therapy where you have a specific monoclonal antibody for a specific cancer, and then you combine the monoclonal antibody with the chemotherapy agent, then the monoclonal antibody binds with the antigen on the cell, and the chemotherapy agent goes. I mean, it's absolutely fascinating. But they don't need to be advertising this to people who are sitting, you know, with high school education, sitting there trying. It's just a huge waste of money.
Well, and let's not forget pharmaceuticals like OxyContin being pushed on.
Oh yes, well that's a whole
another
issue.
But
yeah.
that's another type of infiltration,
well,
corrupting the system.
Yes. Next, the other thing that the money goes to is political contributions. That's a big deal. This system would not exist without the political contributions.
Right.
And the senior senator from Kentucky has turned political fundraising into an art form. Let me tell you a story about the politics. There was a general surgeon, actually recently died, here in Louisville, who, a good general surgeon, about 25 years ago. He retired, and he ran for state legislature. And I think you know who
Yes.
it is. I think he ran for the House of Representatives.
That's correct.
He gave a talk, and this was, again, probably 20 years ago, to the Louisville Surgical Society, and there were two points that I remember clearly from that. One, the first point was that he talked about making laws, and he described it as making sausage, and he gave an example of where he had sponsored a bill, and the bill went through the committee system, and by the time the bill came back to be voted on, he ended up voting against his own bill because it had changed so much. And the other thing he said, which was very clear and very direct, he was very clear about this, and he said the politicians don't understand health care. They're lawyers, they're businessmen, they may be pastors. They really don't understand it, and they're literally led around by lobbyists.
Well, I think most doctors don't understand medical care. I mean, they understand how to practice medicine and take care of patients.
Well, I think you're right. Okay, aside from next down the list is executive compensation. Now we both have lists of people making. Today it looks like back in 2003 and 2004, those were the glory days of executive compensation for the for-profit insurance companies, and a lot of that changed after the economic issues that happened in 2008. So most of the salaries have come down from 45 million or 90 million down to 20 or 30 million. But that's just the top guy. That's the CEO.
Right.
The CEO is maybe going to get a few million less, and the CFO, and you go all the way down this food chain of people feeding off the system, making huge, huge amounts of money. Then, next item down the agenda are investments. So they take money that they've got laying around, they invest it, and they make more money. And this money doesn't go to reduce premiums or change anything. This money just goes into somebody's pockets. And then, as I mentioned earlier, the claims are that are paid. That's called a medical loss ratio. So when you get finished siphoning all of this money off the top and then pay the claims, the money that's left over either goes to investors or it goes to executive bonuses.
Yeah,
I mean,
and
this is an insane system where healthcare is used, where it's literally exploited for this purpose.
Well, I think that money should go to patient care and or to reduce premiums. It shouldn't go to administrators and.
Well, what these administrators have done is they have put together this insanely complex system that the patients have to endure in order to get coverage, and the provider has to endure in order to get paid. And this involves pre-authorization. It involves co-payments. It involves deductibles. It involves coverage denials. It involves co-insurance, uncovered services, networks, surprise billing. Now, one of the things I learned recently that surprise billing is now a revenue enhancer for many of these investor-owned health facilities, like a for-profit ER. Rather than stay in a system or in a network, they stay out of the network in order to send these surprise bills out because they make more money from it. And another group that does the same thing are investor-owned physician staffing firms, which also uses surprise billing, to enhance their revenue. So, I mean, this system is these administrators have put the system together to find as many different ways to extract money out of the system for other purposes than to pay for health care.
Well, let me just tell you a recent episode in pharmacy I had. I'm on a drug called Brilinda, which is an antiplatelet drug because I have a stent in my heart. And so I've been taking this drug since 2017. I went to the pharmacy 2 or 3 weeks ago, and they said it's going to be $1,000. I said, well, I've never paid that much for this drug. And they fooling around and got on GoodRx, and they said they can get it down to $3.50. Well, I started looking on the internet, and they had a coupon where you could get the drug for $5. And I said, well, can you get to me this drug for $5? And they said, no, that's only if you have private insurance. If you have Medicare, you can't do that. So I talked to another pharmacy at our hospital. He said, oh, it's against the law for Medicare to do that. They can't take rebates. So the people on Medicare have to end up paying more. They can't take the rebates. It's actually against the law on Part D of Medicare. And Mike, you've had a similar story, haven't you?
Yes, I had a similar situation with Eliquis,
Right.
where the price went up after a couple of refills, and I ended up having to negotiate with a pharmacy benefit manager group. So, I mean, we talked about them the last time we were in here. They have their fingers in the food chain or the chain from the manufacturer to the wholesaler to the insurance companies to the pharmacies and to the patient or client. And again, this is just another example of all of these administrative personnel that have insinuated themselves in between the provider, the physician, and the recipient or the patient. Again, let's a little bit back to this for-profit health insurance company. You know, we've got what, over 1,000 companies with 20 or 30 different plans, and the quality of your coverage is going to depend upon your premium. So if you pay a lot of money on premiums, you get good coverage. If you belong to a large group that can negotiate, General Motors or something like that, they can negotiate with insurance companies and get a good good coverage at a low cost. You have a low cost plan, you've got poor coverage, and something bad happens, you're out. You're on your own. You file for bankruptcy. Now, we talked about this a little bit the last time we were on here, and I think I had the numbers wrong, but we had a retired gynecologist on a couple of shows ago, and her husband is a dentist, a solo practitioner in a small office with a small number of other people in the office who apparently all had health insurance from other sources. So she and her husband, their health insurance policy for the two of them, and these are not people with a lot of pre-existing conditions, cost $1,000 a month. I had my health insurance plan at U of L before I retired was $200 or $300. It was a couple $100. It was much less than that, and they're $1,000 a month. That's $12,000 a year, and they have an $8,000 deductible. They've got to burn through $8,000 of out-of-pocket costs before the health even kicks in. And then you get into all of these other things like the deductibles and the co-payments and all of the other stuff. So it's a remarkable system. I know we're getting short on time, so we're probably going to have to finish up here. I would suggest that we continue this with part 3 when we talk about investor-owned, because we haven't even gotten to that yet. So...
Well, if you're a small company, say you got 50 people working for you, healthcare is your biggest cost problem, and you end up paying the same, but you got to increase the deductible up to $10,000. Well, most people who work for companies like that don't have an extra $10,000 floating around. And for self-employed people, particularly in rural America and farmers, they can't afford it. I've had many patients whose wife worked in a factory so that they could keep farming and so they could afford their insurance.
All right, single-payer profits for the 85 top publicly traded for-profit health insurance companies. I don't know which ones these are. This is New York Times, Sunday Review, 17 November 2019. $47 billion with a B. That's a single quarter profits for 85 for-profit health insurance companies. There are over 900 others out there with their hands in the cookie jar. So if you multiply this times 4, you've almost got $200 billion of money that is just taken out of the system as profit, which doesn't happen in Canada. It doesn't happen in Taiwan. It doesn't happen in all kinds of other places. And I think as we finish up here, it is my hope that somebody out there is listening to this. I mean, you and I aren't getting, the three of us aren't getting paid to come in here and do this. We do this with the hope that maybe somebody out there will be listening. They will think about these things. They will not take our word for this. We're not making this stuff up. That they will go to whatever resource they find useful, Google or whatever, or Kaiser Health Review, or whatever is out there. There's all kinds of podcasts and verify what we're saying, because we're not making this stuff up.
I think we should make you the healthcare czar, but you don't get any salary.
Okay, guys, on that note, let me just say that, again, thanks for coming in from Campbellsville, Dr. Shively, and the jog over here from Cherokee Park from Dr. Flynn. For more information on Kentuckians for Single Payer Health Care, you can go to kyhealthcare.org. We're on Facebook. And if you've had issues with your Medicare Advantage program, please send Kay Tillo a note. Kay's email address is nursenpo@aol.com. nursenpo@aol.com. Kay would really like to talk with you. Single Payer Radio can be heard 3 times a week, Mondays at 2 p.m., Tuesdays at 7 a.m., and Wednesdays at 11 a.m. And just a reminder for our listeners that Forward Radio, WFMP LP, will be having its pledge drive March the 27th through April the 9th. They've got special premiums for donors. And you can always donate to Forward Radio at forwardradio.org. And please show your support. Again, forwardradio.org. Thank you very much.